Medurstand. Understanding Medicine.
I'm Professor Aziz-ur-Rehman, and today we're going to start our series of lectures on infective endocarditis. This is a fairly common condition and very serious one. If diagnosed properly, I think there is a good chance that patient will survive. But if it is missed, then it would probably be invariably fatal if diagnosis is not made and the treatment is not offered. So I think you need to learn this condition very well. Although it may not be easy to diagnose and it is certainly not easy to treat, but of course, if we learn this technique, then you should be able to diagnose these patients and you should be able to manage them independently also. Uh, Definition is always very hard to define anything. Uh, because I think in the real world, the disease does not have any clear boundaries, whereas definition requires that we define anything very explicitly. So I think the definition, the best definition I could come up with was this: an infection of the heart's endocardial surface. Now, this would mean that the endocardium, the heart itself, the valvular structure, the chordae, the papillary muscle, and the great vessels also. So anywhere infection, because normally our endocardium is very resilient to infection, and bacteremias often occur after some febrile illness, but our very definitively intact endothelium does not allow any bacteria to settle in and to establish infection. So there has to be something underlying abnormality. Either the endothelium is not intact or there is some severe and virulent bacteremia that may cause infection. So once infection of endocardium is established, endocarditis is said to be present. There are certain risk factors. Luckily, everybody is not prone to get this serious infection, and this infection is very rare in otherwise healthy people with no underlying heart disease, despite recurrent bacteremias. So if you have a rheumatic heart disease or congenital heart disease, or there is prosthetic valve implanted, or there is the patient is intravenous drug user, and or there is intravenous indwelling catheters like pacemakers. So these are some of the predisposing factors. In our country, I think rheumatic heart disease is perhaps the commonest and congenital heart disease the second commonest. It is also, I think, important because these risk factors, they can also give you an indication of the possible organism. So I think it is important to identify the risk factors. So why rheumatic heart disease and congenital heart disease? Because they cause turbulence of flow and they are responsible for endocardial injury, which is one of the two requirements for the establishment of endocarditis. Now, these are two requirements. I think both need to be met to cause endocarditis in most cases. Of course, there are exceptions. In some exceptions, in some cases, just one may be enough. But usually, both conditions are required to have endocarditis. First one is turbulence. In a normal heart, there is no turbulence. Blood flows very smoothly because valves are wide enough to allow flow smoothly, and there is no regurgitation in a normal heart. But if there is rheumatic heart disease, valvular heart disease, or congenital heart disease, there may be abnormal flow of blood from one chamber to another one, causing a jet effect. That means blood is projected on a specific side, which may cause erosion of endothelium. So once endocardium or endothelium is eroded, that will provide the raw surface where bacteria can settle. normally our blood is sterilized, but sometimes we get bacteremia. So if somebody had this endocardial injury already and happened to have bacteremia at that time, there is a good chance that these bacteria will settle there. Especially when there is endocardial injury, there is actually nature's attempt to repair it by forming fibrin and platelet clots. So these are already there, and bacteria can get entrapped in them and they can cause infection. So, and these infected small clots, they are called vegetations. Okay, so I think in most cases you need a predisposing factor causing turbulence, and then you need to have bacteremia, then you have endocarditis. Of course, there are causes of endocarditis other than bacteria. So, and in sometime otherwise normal healthy person can get endocarditis. So I think it is not that every patient will have to fulfill these two conditions, but mostly I think these two conditions are needed to be fulfilled to have endocarditis. That is why luckily that endocarditis is not a common condition in normal healthy people. Now, pathogenesis, I think we briefly already discussed. First, there is turbulence of flow that is causing endocardial injury, exposing the raw surface that attracts platelet and fibrin, and they make small deposits. And then bacteria, if there is coincidental bacteremia, bacteria get entrapped in them and that establish endocarditis. I think one thing which is important to learn here is that these vegetations, they are primarily avascular structures. They do not have capillaries, they do not have circulation. So antibiotics, when given, antibiotic will not be able to go to the depth of these vegetation through the circulation. It will be, the antibiotic will be imbibed from the surface. So that is why these infections are also very difficult to treat. Classification of endocarditis can be from three different perspectives. One is based on natural course. Of course, it indicates the natural course of illness. The natural course of illness could be subacute or can be acute. So according to that, you can give a label. Is it subacute infective endocarditis or is it acute infective endocarditis? Subacute typically affects damaged heart valves, rheumatic heart disease or congenital heart disease, or sometimes prosthetic valve also. And it has got an indolent nature. That means not very acute. It develops gradually over a period of weeks. And common organism in this situation is streptococci, either strep viridans or strep faecalis, because these two organisms are relatively, I say relatively easy to treat as compared to some other organisms. And of course, if not treated, these patients will ultimately die. So this is important. Though condition is relatively subacute and organisms are relatively easy to treat, but if diagnosis is missed, these patients will ultimately die. Then the acute endocarditis can affect normal heart valves. Somebody with no underlying heart disease, and he can or she can have endocarditis. Okay, and this usually develops in some specific situation, and we will discuss, I think, in one of the slides. It is usually rapidly destructive. Why? Because the very fact that these organisms have settled in a normal heart means that these organisms must be very virulent. And commonly, these organisms are Staph aureus or Staph epidermidis. So that is why this condition is relatively difficult to treat. And if untreated, it would lead to death in a short period of time, relatively as compared to subacute. So this is one classification, subacute and acute. Traditionally, we used to see subacute endocarditis. Only with modern life, with more and more indwelling catheters and more prevalence of intravenous drug abuse and more hospitalization in intensive care units, this condition is emerging now, acute endocarditis. So this is one way of classification. Second is based on setting. This is perhaps a duplication of the same, but I think if you look at something from different angles, it will give you a very good idea about the nature of this disease. So based on setting, native valve endocarditis, that means your own valve got infected, and then prosthetic valve endocarditis, somebody had a prosthetic valve and that got infected, and this would be further classified into immediate post-op or later because the etiology may be different. And then intravenous drug abuse endocarditis, because these patients, they use dirty water, dirty syringes, they usually share syringes also, so they can actually inject virulent bacteria right into their circulation, so that is why they may cause serious infection. And then nosocomial endocarditis, the endocarditis which occurs in the hospital, because organisms in the hospital are generally very resistant to antibiotics. So I think somebody who was admitted for some other reason with intravenous lines, if that patient develops endocarditis, that would be very resistant bacteria. So this classification is based on setting. Now this will help you if you have a case of endocarditis. If you study the settings before you receive the reports of blood culture, you would have some idea that which organism may be actually responsible for the infection. And at least empirically, you can start the treatment before you receive the culture reports. The third is based on etiology. Of course, it perhaps is the best if you know what organism. Is it bacteria, fungi, or some atypical organism? And if it is bacteria, is it strep or staph? If it is staph, which staph? And if it is staph, which strep? So if you know the exact bacteria responsible for infection, and if you know the bacteria, you would probably also know the culture sensitivity also, and you would know which antibiotic will be the best. So this is perhaps the best classification, but the problem is that exact etiological diagnosis is not possible in many cases, especially in our setting. The reason is that when we receive the patient may be already taking antibiotics, and sometimes there are some organisms which do not grow easily. So I think we have to start medication after sending the blood culture, and once we receive the culture reports, then of course we then reassess if the bacteria responsible are resistant to the antibiotic being used, then we change the antibiotic. Streptococci viridans or faecalis. Mostly viridans, but in some cases it may be faecalis. Both are streptococci, both respond to penicillin-based therapies. Then we have staphylococcal infection. Staphylococci are of two types: methicillin-sensitive Staph aureus. That of course means that methicillin, is a penicillin derivative, but it is beta-lactamase resistant. So if somebody has staph infection but is sensitive to methicillin, he will be classified as methicillin sensitive Staph aureus infection. There may be another guy who may be more unlucky, may have infection with Staph aureus which is resistant to methicillin, and this would be classified as methicillin resistant Staph aureus infection. Now this is Staph aureus. Then there's another staph called Staph epidermidis, which is actually even more difficult to treat. Then we have HACEC. HACEC is a short of multiple organisms which actually are difficult to grow and difficult to respond to treatment. And then Coxiella burnetii, and then Bartonella species, and sometimes fungi. These organisms, they are actually responsible for endocarditis in immunocompromised people, and they constitute a special group because we can't really treat these patients without the culture report, without the sensitivity pattern, because guess won't work here, but here we can use the therapy on empirical ground. So these are the risk factors. I think we have already discussed. These are the risk factors. So we can skip this one. Infecting organism also we have discussed. I think we can skip this one also. Now the symptoms. Symptom, the main symptom, and then some unusual symptom. The main symptom is, I think, prolonged fever. Somebody with an underlying condition presents with prolonged fever and with these non-specific symptoms. These are actually non-specific. Any chronic infection like tuberculosis, like brucellosis, all those infections would cause these symptoms. But prolonged fever in a person who has some predisposing factor and has one or more of these, I think that is how we suspect. Then there are some physical signs. Some are very important, some are less important. Now the main, I think, physical finding is heart murmur. Heart murmur would represent rheumatic heart disease as well as congenital heart disease. Two of the major predisposing factors would be indicated by the presence of heart murmur. So if there is a heart murmur, then I think your suspicion in a patient with fever is very, very high. Then splenomegaly may be present. There are many other signs and we will discuss them later, but this is just a short list. Petechiae, small punctate hemorrhages present in various parts of the body. Then subungual or splinter hemorrhages. These are small hemorrhages under the nail. Clubbing may be present and Osler's node may be present. I'm going to show you what these are. Janeway lesions may be present and Roth spots may be present. These lesions are immunological, many of them at least are immunological in nature, and they would take time to develop. So these conditions, these signs will be expected in patients with subacute bacterial endocarditis rather than acute bacterial endocarditis, because acute bacterial endocarditis is relatively short illness and there is not much time to develop these signs. So if these signs are present, most probably patient has subacute bacterial endocarditis, and you will have to have a very, very thorough examination to pick up these findings. Small lesions can be easily missed. Now these are the signs. You can see the clubbing, the clear-cut drumstick appearance of these nails, and you can see the convexity of the nail is increased and you can see this prominent. Of course, this is grade 3 clubbing, and I can see some cyanosis also. Cyanosis would be present if the underlying heart disease is causing cyanosis. Perhaps endocarditis would not cause cyanosis itself. Then we have these petechiae, a small punctate hemorrhage you can see in the conjunctiva, and they can be present on the skin and they can be present on the palate, uvula. So I think if you examine carefully, these punctate spots should be a sign of endocarditis. Of course, you can have these spots in purpura also, but one of the causes of these spots is endocarditis. Now these are splinter hemorrhages. Splinter hemorrhages are typically non-blanching. That means if we press on nail, they would not change their shape, they would not disappear, because these actually represent actual blood outside the capillaries. So, and they are linear reddish brown lesions. Why linear? Because there are some potential spaces which are linear where the blood accumulates, and they are different color, not red, because of the age of the blood, and found under the nail beds, usually do not extend the entire length of the nail. So it usually will have few millimeter, but usually do not go all the way to the other end of the nail. So this is the classical sign, splinter hemorrhages present in a person who is otherwise a predisposed case. Fever with murmur, these signs I think surely would indicate endocarditis. Then these are the signs, these are called Osler nodes. Osler nodes are because of the person who described, the scientist, the physician who described the Osler. I think these are the painful and erythematous nodules located on the pulp of fingers and toes. Now, why they are painful? Because they are actually inflamed lesions. They are infected and inflamed lesions, and they are erythematous because they are again vascular. So that is why they are painful and erythematous. They may be one, two, three, or many, and they would be of different ages. You can see one here, and there is another one here, and there is one small here, either one here, and there are some two or three here. You can see that they are of different colors because they have different ages. So these are nodules, and the classical feature is that they are tender. They're a small, if you touch on them, they would be tender. To differentiate them from another lesion of endocarditis, which is called Janeway's, I think that is not tender. Yes, these are the Janeway lesions, and these are erythematous, like the other one, blanching because these are actually dilated capillaries and non-tender macules. Okay, so blanching means because when you press on them, they would disappear. That means that it is actually not the free blood in the subcutaneous tissue. It is actually the dilated tuft of capillaries. That is why when you press, the blood disappears, and when you release the pressure, they come back. So these are called Janeway lesion. Again, after the name of the person who described them. Then I think essential investigation. Uh, in any patient who is very sick, we do number of tests, and this patient would also undergo many tests. But I have identified two investigations which I would call essential. And these are number one, blood culture. I think it is mandatory that you draw blood cultures in all patients who are suspected to be cases of endocarditis. The problem would be that if somebody is already on antibiotic, in our country, people just start antibiotics on their own, or the local physician will start antibiotic without even bothering the underlying cause. So if that is the case, you must stop the antibiotics, wait for 2 or 3 days, maybe 72 hours, and then send blood culture. And if patient is not on antibiotics, then you straight away start taking cultures, and it is recommended that you take at least 3 cultures. And what is the philosophy of 3 cultures? Because average yield of positivity in one culture is like 30%, 33%. So you are not going to find the organism in one culture. So if you do 3 cultures, then your chances of finding an organism is close to 100%. Separate vinipuncture sites and obtain 10 ml, add to the broth. There is a special broth which is meant for the transportation of this sample to the laboratory, because these bacteria are very slow to grow. First we have to allow them to grow in the blood. The broth is also that on blood, and then in the laboratory. And you must use proper sterilized technique, because many times when we receive the blood culture, we are uh, disappointed because the organisms grown are the skin commensals. So I think you must sterilize patient skin, and you must wear proper surgical sterilized gloves when you take sample. And the second most important test is echocardiography. And echocardiography could be the transthoracic, which is easy. It may show vegetations or some other findings of endocarditis. If that is not, if that echocardiography is negative, the transthoracic echocardiography is negative, but the suspicion is high, then we go for transesophageal echo. This is like an endoscopy. We pass a instrument inside, there's a small probe. We get very close to the heart without intervening bone or lung, so we get much better picture of the heart, and a small vegetation, abscesses, and other features can be identified. So these two are essential investigation for the treatment of endocarditis. I think blood culture must be done before you start antibiotic. They should be sent, because typically, typically blood culture takes about 6-7 days, maybe that is the time, sometimes even longer, 4 weeks. So you can't wait for that long. You send the blood culture and then you start the treatment on empirical basis. Okay, so these tests would also be done in CBC. You would expect some leukocytosis with some mononucleotide cells and neutrophil. ESR would be elevated, CRP would be elevated because both are signs of inflammation. Urinalysis might show some red cells, some protein, baseline chemistries, because these patients are very sick. We need to know their liver status, their kidney status, their electrolyte status. So I think we need to have their baseline tests, including blood sugar, and then ultrasonography of the abdomen to see if some complication has already developed, maybe splenomegaly, maybe some abscess formation somewhere in the abdomen. So all these investigations, maybe then X-ray chest also would be needed, ECG may also be done. So all these investigations may be necessary, but the two essential investigations are blood culture and an echo. So diagnosis, how do we make a diagnosis? I think by now you must have figured out how to make a diagnosis, but the best way is to make the diagnosis based on modified Duke criteria. Now these criteria were given by Duke University. Now let me first give you some idea about the criteria-based diagnosis. Criteria-based diagnosis is very likely to be correct because you have fulfilled certain criteria, but the diagnosis is likely to be delayed. So a good physician would probably not wait for all the criteria to be met to make a diagnosis. So based on the patient condition, based on high index of suspicion, I think I would like to make the diagnosis of endocarditis before the criteria are fully met. But you need to know these criteria, and I'm going to present these criteria. I think important for you to know. One is definitive pathological diagnosis. Now, this actually is not clinically applicable, but I'll tell you what I mean by definitive pathological diagnosis. Then we have a definitive clinical diagnosis. This is what we work on. Clinical, as a clinician, we do something to get a definitive clinical diagnosis. And then extremely important concept, this is a relatively new one, rejected diagnosis. That means we may be both pondering if it is the endocarditis or not, but something comes up which tells us no, it is not endocarditis. And this is a rejected diagnosis. Okay. So whenever you are trying to make a diagnosis of endocarditis, you could have one of these three situations. Now let's discuss them, what they are. A definitive endocarditis, pathological sense, is microorganism found inside a vegetation or an embolus. So either when you are doing an open heart surgery, sometimes you have to operate on these patients, you remove a vegetation and then you do the microscopic examination, you find some organism sitting right inside the vegetation. Or patient had thrown the embolus into some artery and you get an embolus and then find the organism in that embolus. So that is definitive pathological diagnosis, but it has got limitation. We can't make our clinical diagnosis based on this. So what is the definitive clinical diagnosis of endocarditis is based on Duke criteria. Now there are multiple criteria. I'm going to show you any two of the three major criteria. There are three major criteria and any two, if any two are met, the diagnosis of endocarditis should be considered definitive as far as clinical approach is concerned. Now I'm sure you know those. One is a definite positive culture. Now why do I say definite blood positive culture? Why I simply do not say positive culture? Because positive culture may be due to commensals, the skin commensal. So we need at least 2 blood cultures which identify the same organism, and that organism we know that is or can cause endocarditis. So there has to be some plausibility. Okay, so 2 different cultures should be positive, and only then we say that blood culture is definitively indicative of endocarditis. And then definitive vegetation on echocardiography. Everything, every small thing attached to the endocardium is not actually vegetation. So if the report is that these are different vegetation, there are certain characteristics of vegetation. I think we need not go into the detail. The cardiologist or a technician will tell you if vegetation are present or not. So a definite vegetation if present, that is the criteria number 2. And the third criteria is definite new regurgitant murmur. Now this was actually added in the modified criteria. This one was not included in the first due criteria. This was added later. So it assumed that there was no murmur before this febrile illness developed. And so during the illness, during a febrile illness, if a new murmur appears, that implies that one of the valves has ruptured actually, and that would happen only if the valve is infected. So this is also an important criteria. Any 2 of these 3 criteria, if positive, you can make a definitive clinical diagnosis of infective endocarditis. All right, so easy. Then the other is that one major out of the 3 I just mentioned, any one of them, plus 3 of minor criteria. Now I'm going to show you the minor criteria here. Predisposition. That means you know that this patient has a murmur, or this patient is a drug user, okay, or this patient has got an indwelling catheter. That is predisposition. Then fever, which is 100.4 or higher. Then some vascular phenomenon, which is actually known to be associated with endocarditis, emboli, intracranial hemorrhages, Janeway lesions. And then immunological phenomenon like glomerulonephritis, Osler nodes, Roth spots. Roth spots are some spots which are seen on the retina. Positive rheumatoid arthritis factors, so they would all indicate immunological phenomena, so that could also contribute to the diagnosis. Then microbiological evidence of serology, some antibodies against a specific organism, if that is present. So these are actually all relatively non-specific, so that is why you need to fulfill 3 out of this plus 1 major criteria, then you can make a diagnosis. Okay, so I think if you have learned this one, the next one would be easy. The third category is all 5 criteria are met. I can't really imagine somebody who meets all these 5 criteria but does not meet even one single major. But theoretically, if somebody does not have any major criteria but has all 5 minor criteria, you can still make a diagnosis of endocarditis. Many times we have to start treating these patients assuming that they have endocarditis, because sometimes definitive evidence may be lacking. A patient may be getting very sick, so we have to take a decision and start treating this patient. So finally, the rejected diagnosis, you were pondering, you were working on the diagnosis, but suddenly something came up that tells you that this is not endocarditis, because one is there are 2 conditions where you can reject the diagnosis. Resolution of illness within 4 days of antibiotic therapy. You know, endocarditis is very hard nut to crack. So if somebody's all symptoms, they resolve in 4 days. I'm not just saying just patient becomes afebrile, because with analgesia he may become afebrile, but if his condition completely normalizes then I think the diagnosis of endocarditis is very, very unlikely because we don't expect that fast response. That means it was some other infection and that has the patient has responded to the antibiotic dose. And during workup, you found something very clear-cut, alternate diagnosis. Now, somebody who is predisposed to have endocarditis does not mean that he or she cannot have another infection. Maybe the person is predisposed, but actually he presented with some other infection like tuberculosis, like liver abscess, like urinary tract infection. So if you find an alternate diagnosis which can explain patient's clinical feature, the diagnosis of endocarditis can be considered rejected. So I think this was end of part 1. I'm Professor Aziz-ur-Rehman from Medurstand, and I'm looking forward to see you in the second part, which would concentrate, which will focus on treatment, very, very important, and also the complications. So I think join me in my next lecture on on the treatment and the complication of endocarditis. Thank you.